far as the blood supply to the nephron, and we realize that the kidney is a filtration system that then selectively reabsorbs or secretes substances with the tubular system in order to excrete in the urine whatever is necessary to be excreted, like any waste, but preserve the vital things like amino acids, glucose, electrolytes, and water. We review that a lot of this reabsorption happens in the proximal convoluted tubule, and then selectively across the loops of Henle and the distal convoluted tubule. We have different hormone systems, and we have different receptors that are the target of some of the diuretics that we use that will then fine-tune the amount of sodium, potassium, chloride, bicarb, and water that you reabsorb or end up secreting. Lastly, we talked about the JG cells. I said it correctly. And we talked about how their relevance as far as GFR, glomerular filtration ratio, and blood pressure control. We also talked about myogenic stretch, so the local activity of the efferent and afferent arterioles and the role that prostaglandins have on that in controlling locally GFR and renal blood flow. I think we finish up by saying the role of NSAIDs and ACE inhibitors on blunting that effect of prostaglandins and being mindful of their use perioperatively when we have to anesthetize a patient, given that that decreases our cardiac output, and cardiac output is super vital for GFR and renal blood flow. The kidneys need 20% of the cardiac output, at least, to do their job. So now we're going to basically talk about fluid therapy, if we don't have any questions. Have you guys had any lectures on fluid therapy?
Yes.
Yeah. Who gave it to you? Dr. David. Okay. Excellent. So can we skip this lecture? It's sunny outside. Well, I'll give you my perspective on fluid therapy. The important thing is to remember that fluid therapy, whether you do it IV or you do it by mouth or you do it sub-Q, basically what you're trying to increase is the water content of an animal, right? Water or volume is more important than red cells as far as increasing your oxygen delivery to the tissues. With that, I'm saying that a hypovolemic animal needs to be treated for that volume deficit much more than an anemic animal needs to be treated with red blood cells, right? In order to increase the oxygen delivery or nutrients to the tissues. So a patient in shock has to be treated way sooner than a patient that is dehydrated or anemic, if that makes sense. Obviously there are exceptions to that rule, but that's important. So the first item to focus on as far as talking about fluid therapy would be water. How does water travel from one compartment to the other? And then keep this proportionality in mind. So we have 3 fluid compartments. What are they? ECF, ICF, blah, 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 blah. So ECF, right, extracellular fluid, everything that's outside of the cell. As you can see in that diagram, is composed of plasma and interstitial fluid. Interstitial fluid is the fluid in between the cells, basically where the cellular matrix is, okay? So you need to have water in that system so that you can get diffusion, right, of gases and nutrients. And then plasma, obviously you need it for the cells, like red blood cells, to go from one organ to the other. And then we have this intracellular fluid inside the cells. We don't really have much impact on that with fluid therapy, so we can put that away for the moment. So we're going to focus on the extracellular fluid. However, which compartment is the biggest one here?
Easier.
Easier.
Yes. This one, is this the biggest compartment? Who votes yes? So there's more water in your cells by far than anywhere outside of the cells, okay? So that's important because it's not water that we can actually do much about it, okay? So your cells are, your water, 66% of our water is here, untouchable, can't do anything about it. 33% is outside, divided into these two compartments, okay? That's huge, you gotta know that. So, for example, if I'm 100 kilograms, pure muscle, 100 kilograms. That means I have 100 liters of water in me. 1 kilogram equals 1 liter. That's important to know too. If I have 100 liters of water, 66 liters would be in my cells, 33 would be available to play with. Make sense? This is important. Out of those 33 liters that I have here, which one will be bigger? Plasma volume or interstitial volume? Interstitial, right? So the plasma volume, ironically, when we put the IV, is the smallest one of all. And what is the ratio there? The ratio is 1/4, 3/4. Right? I'm going to break it down again. Total body water, meaning, if I have 100 liters of water, that would be a lot. 66 liters would be in my cells, 33 would be outside, and out of those 33, 1/4 would be in my plasma, my blood volume, and 3/4 would be in my interstitial fluid, i.e. hydration. Okay? That's all we need to know about water compartments. Now, why does the cell have so much water? Well, it needs it for all the metabolism and to keep a certain amount of tension in it so that things can go in and out, right? But the question, a more important question is what keeps the water in there? Water can freely diffuse everywhere, right? There's nothing holding water back. So what holds water in the plasma? Albumin. That's important. Albumin. What holds water in the interstitial fluid? Sodium. Mainly. That's why sodium is your highest electrolyte in your blood panel, right? At 145 roughly milliequivalents per liter. What holds water in the intracellular fluid? Yes, excellent, potassium. That's why our potassium blood levels are really low. More 4 milliequivalents, because the rest is going to be in the cells. So basically, water can do whatever it wants. It's the electrolytes and the albumin that's dictating how it balances itself. Make sense? So if I want to influence water, I can influence albumin, sodium, and potassium. So now let's focus our attention where everyone wants to be, which is at the blood level, right? Plasma level. So I'm at the level of the capillaries here. This is how fluid goes in and out of the capillaries. Let's say you put an IV and you have blood flow coming in. What's pumping blood into that capillary? Essentially your heart, right? Heart is a heart rate, stroke volume, right? So stroke volume per beat. And then multiply that by however amount of beats you have per minute. And that's the blood flow down. You also have constriction of those capillaries, right? Because if they're very floppy, you're going to have decreased blood flow as if you have some tone into it. And that's called vascular resistance. If you combine cardiac output with vascular resistance, you have the definition of blood pressure. So blood pressure is what's giving us blood flow down the capillary. If you push out very hard on your fluids, they're going to get out right of that capillary due to hydrostatic pressure. That's the pressure that the water column does. And where is it going to end up? Interstitium. And that's called edema. Right, excellent. So there's another force that's pulling or balancing that one, and that's called the osmotic pressure. Don't get confused with oncotic and osmotic. Don't get confused because I'm going to make it the same. Alright, just for simplicity in this course. So if you hear me say osmotic, oncotic, just go for the same. But there's a balancing force so that water doesn't leave and then you become super hypovolemic, right? And super overhydrated, if it makes sense, right? So when that blood flow is going hard on the arterial side, then what happens with the inner part of this system is that your proteins get concentrated, right? Because your water is leaving. So what's left behind is sludge, albumin, in concentrated forms. So that counteracts the hydrostatic pressure at the outflow end of that capillary, or the venial end. And so now we have water going in. And that balances out so that you don't drown yourself with edema. So hydrostatic pressure forces are higher on the input end, which is the arterial end, and then they're lower on the venial end, and the oncotic pressures are the opposite. They're lower on the arterial end, and then they get higher as the water leaves that system. Is that clear? That there's always going to be an excess water leaving, always. That's why you have the lymphatics. But the oncotic or osmotic pressure will buffer that to a very high degree. You have a patient with heart failure and low oncotic pressures, no bueno, right? If you have a patient that has low albumin, I have one in the ICU right now, no bueno. So you want to keep a tight rein on how much fluids you're giving and also what your albumin levels are. All the time when you do fluid therapy, okay? Now this is starting forces. This is the name of the forces that work across the capillary to get filtration. Again, because you always have a net filtration, unfortunately, so your lymphatics are always working. That's why we have maintenance fluid therapy, right? Otherwise, we wouldn't need any fluids. But you always have a loss. And your lymphatics take away the excess water in the interstitial fluid. But I'm just going to tell you that this doesn't exist at all in our body, or in the dog's or cat. It doesn't work like this at all. But conceptually, it helps for us to do fluid therapy with it. So if you want to know how it works, well, I would need 3 more lectures for this. But the key word, and the only thing I'm going to leave you behind, if you want to know more, is called the glycocalyx. That's a huge thing that's coming up in fluid therapy right now, human and veterinary medicine. The glycocalyx. And it's a little set of like beer, or like, I don't know how to even call it, but like flagella that comes out of the endothelium. And apparently that barrier there is where all of this is happening. It's not happening across the endothelium. Why is that important? Because if you blast a patient with fluid therapy, you destroy that glycocalyx. Why is that important? Because head of starch is becoming a no-no everywhere in the critical care world because you're damaging the glycocalyx. So I'm going to leave it right there. And the takeaways from that is that this is great to learn how it works, but it's not how it really works on the human. And the second takeaway is that now we're reconsidering our fluid boluses a lot more because we want to preserve that glycocalyx. And we're reconsidering a lot more our starch uses. Vet starch, head of starch, any fake colloid. To the point where in emergency medicine they put a black box sign on head of starch. You cannot give head of starch by the FDA anymore. That's a bummer. And we will talk a little bit more about this, but I want to leave it there because this is the part of the lecture where I should put it in. But I'm going to review it again, don't worry. So these are the lymphatics. They basically look like a bunch of capillaries too. They're in green. And they basically serve as a sink for the excess fluid that gets filtered out from the capillary to go back where? Where do they drain, the lymphatics? The right atrium, right? Thoracic duct, right atrium. So essentially they become part of your venous circulation again. And the lymphatics can increase in capacity. That's why patients with heart disease can sustain months before going into failure, even under the conditions of excess blood volume and high hydrostatic pressure, because the lymphatics are overworking. This is what is, the lymphatic, when they grow, that's when you see the perihilar interstitial pattern in a heart failure patient. You don't see them with edema, you see the perihilar interstitial, because the lymphatics are long. That's where they live. All right? We talked about, the important part of this slide is like, look at the cell. The cell protects itself. As long as you have energy, as long as you're not in lactic acidosis, as long as you're not hypoglycemic, your cells are always going to protect themselves from fluid shift by using that sodium-potassium pump. Your sodium-potassium pump, this thing is an energy-dependent pump that pumps sodium out constantly against a gradient, right? Because there's more sodium in the interstitium. So I'm going to pump against that gradient, and I'm going to let potassium against the gradient. And I'm doing that because if I take sodium out, water leaves. So I can control the amount that I pump sodium out so that I can control my water levels. And that's why I'm saying that the cell is like independent of water shifts, unless you're super hypoglycemic and you have energy, or you're super lactic acidotic. And those are the patients that then get potentially cerebral edema, right? So for the most part, fluid therapy, the discussion should be at the blood level and at the interstitial fluid level. That's it. So it makes it easy. We talked a little bit about this, but if you forget, looks at the osmotically/oncotically active particles in each compartment, and see that water can do whatever it wants. Another thing to consider is when we talk about whole blood, 50% of that is plasma, water, and 50% would be cells. The majority would be what? Red blood cells, right? By far. But don't forget that whole blood is not just a bunch of volume. 50% of that volume is the water level, and then 50% is cells that you can't do anything unless you transfuse. Make sense? All right, so let's talk about part B here, blood volume. So now we're talking blood volume. I'm talking cells and plasma. The blood volume of a dog is 80 mils per kg, roughly. We don't know, like it can depend dog by dog. It's not even dependent on breed. So you can have a pug that is 2 years old and it has an 80 mil per kg volume, and the sister can have 90 mils per kg. It's just how it is. But if you remember roughly 80 mils per kg, I'm happy with that. So how much of that is plasma? That's the blood volume. I'm in the blood, I'm not talking about any other compartment. I said that it's 80 mils per kg. How much of that is plasma? 40 mils per kg. Okay? And the rest, 40 mils per kg, roughly would be of cells. Okay? What about a cat? It's 60 mils per kg. Some people say it's 45. They're more conservative. So let's say between 45 mils per kg and 60 mils per kg is the blood volume of a cat. So there's different terms here. When you say hypovolemic, you have decreased intercalating blood volume rate. When we say hypovolemic shock, what do we refer to? Essentially, we're losing plasma volume. We could lose just plasma volume if we're vomiting, having diarrhea, having polyuria because I am diabetic, right? Or polyuric because I am in renal failure. Yeah? And so I'm decreasing my blood volume. But in that sense, I'm only decreasing the plasma volume, right? But I can lose whole blood. How can I lose whole blood? Damn it, if I can. If you chop my arm right now, right, I'm going to bleed, and I'm going to bleed cells and plasma. So we have to keep that in mind when we treat with fluids. Essentially, if you chop my arm and I'm bleeding to death, please take me to Auburn, some hospital there. But that would be Are you gonna give me just water? Right? I guess initially you will because it's easier. You're gonna give me plasma, just plain old fluids, right? But at some point you need to replace the cells. Versus if I'm vomiting and having diarrhea, also taking to over. You can replace it with saline, just saline, right? We don't need cells at that point. In fact, probably my cells are going to be concentrated. My proteins are going to be concentrated. So I just need plasma volume. I need saline. All right? So there's a very simplistic way of thinking of fluid therapy. So in summary, hypovolemic shock can be a contraction of your plasma. You have a smart fly that wants to... Contraction of our plasma, or it could be contraction of our whole blood, depending on what caused the loss. Now, when we talk about dehydration, dehydration would be interstitial fluid deficits. So I could be normal bulimic, I could have normal blood pressure, I could have normal blood volume, and still be dehydrated, okay? And that would be an interstitial loss. Ultimately, you can get so dehydrated, right, that you're going to suck fluid from where? From the blood. And you can become hypovolemic, right? But that's at the 10% bracket if you read this chart. So on the 10% bracket of dehydration, and what 10% of what? 10% of a magic number or what? Where's that 10% coming from? 10% of my body weight, okay? So again, if I'm 100 kilograms, I have 10 kilograms of water deficit if I'm 10% dehydrated, which is the same as 10 liters or 10 bags of fluids, okay? At that point, when you're 10%, you are going to be sucking fluid from the